This is QD Clinic from ACR22. Hi, I'm Dr. Jack Cush with Room Now. In this series, we're going to feature some important abstracts from ACR 2022 being held in Philadelphia. Today, I'm going to talk to you about a case I saw about a year ago. A 17-year-old Hispanic male presents with fever and rash. He has temps up to 104. He has a rash that comes and goes. He has chest pain. He has lost weight recently. He has no appetite. He has a few tender and swollen joints. On further investigation, he is found to have splenomegaly and hepatomegaly, mild elevation of his LFTs, a white count of 64,000. That's right, 64,000 with a left shift. Chest x-ray shows that he has pleural effusions bilaterally. And on EKG, there's evidence of myocarditis. What would you do to treat this man? That's not hard. This is a patient who clearly has systemic JIA or Still's disease. This patient is really sick. In fact, he went right into the ICU. It's not hard to imagine that you would go ahead and pull out all the stops and give him all your big guns. So he's going to get, big doses of IV steroids. But what do you use as your disease-modifying drug? Do you go straight to biologics? Do you use a DMARD like methotrexate or azathioprine? I'll point you to the result. First off, I'll point you to the ACR guidelines from this year that says it is okay to use biologics, IL-1 or IL-6 inhibitors as first-line therapy in active systemic JIA. And that's supported by this abstract, a late-breaking abstract number 12, or L12. It's presented by Erkins and colleagues. It's going to be presented with the late-breaking abstracts on Sunday at this year's ACR. The title of their presentation was First-Line Recombinant IL-1 Receptor Antagonist Therapy, meaning Anakinra, in New-onset Systemic JIA. This was a multi-center, multinational study where they collected patients who had new-onset JIA. There were 65 in all. They were half male. The average age was 7 years, and the age ranged from 8 months to almost 16 years of age. As far as first-line therapy, of the 65, 60 of them were given Anakinra as first-line therapy, meaning over a DMARD. 5 others received corticosteroids first, but then soon thereafter got Anakinra. You can use Anakinra with corticosteroids, obviously. The outcome here was pretty impressive. 70+% of patients had a complete response, meaning that they were off steroids and had clinically active disease within 6 months. That was maintained. That same number was maintained for 12 months. When they did a total of 2 years of follow-up, they basically showed that 20% developed macrophage activation syndrome, and that would have been during when they were most active. It's quite unusual to be clinically inactive and then, boom, have MAS. The other interesting thing that they found in their report was at least 62% had eosinophilia, which was surprising. One of the purposes behind their doing this study was to look for this association of a certain genotype with this rare interstitial lung disease, or lung disease that by many people is thought to be a sort of a DRESS syndrome, a sort of systemic allergic reaction, usually in people on biologics. And so they, as part of their study, they did genotyping, and basically they showed that genotyping, looking for HLA-DR beta 1.1501, which was the highest association, was not really seen with any good frequency. I think that they found that 26% actually had this allele, and a few other alleles were found, but they really didn't predict outcome or toxicity. Only one of the 17 patients who had this particular haplotype of HLA-DR beta 1.1501 developed systemic JIA ILD in the 2 years of follow-up, making it not that predictive. So while this study didn't reveal what they had hoped to reveal, which is the use of the genotyping in finding at-risk individuals for lung disease, which is very, very rare, they did show that first-line therapy with Anakinra is prudent and wise in sick patients with systemic JIA. Hope you enjoyed this report. Tune in for more QD clinics from ACR 22.